Good evening. I'm Dr. Laura James. Welcome to my latest short forum event. This evening's topic is breast health, screening, cancer diagnosis, and genetics. In honor of Breast Cancer Awareness Month, which is this month, I wanted to do a brief overview of issues surrounding healthy breasts, just so that you have the best information moving forward. I see in the audience some new names, and if you have any questions, you can type your question in the dialog box on the side of your screen. Hopefully you can hear me okay. I am going to split my screen, and so you'll see my face, or rather my talking head, and my slides, although I will only see the slides, so I'll have to toggle back and forth a little bit. So if I don't get to your question right away, I'll get to it in a couple minutes, okay? So let's get started. Let's see, just take a minute to set up here, screen sharing, let's see. Oh my. Here we go. So hopefully you are able to see this slide. I'd appreciate it if you could just say, yes, you can see the slides on one side and my face on the other, because I can only see my slides. Yes. Let's see. Are you able to see? This does not look like something you really want to see, but hopefully you'll be able to see the slides, and please let me know if you cannot see both me and the slides. So here we go. Tonight's topic is breast health, screening, cancer diagnosis, and genetics. I'm Dr. Laura James. I am a naturopathic oncologist, and I practice in Bellevue, Washington, and on Maui in Hawaii. Tonight's learning objectives are, I'd like to give you a little bit of an overview about integrative oncology, talk a little bit about what healthy breasts are important for healthy breasts, what current screening recommendations are, diagnostics in cancer, and a genetics overview. So first of all, integrative oncology is the combination of natural medicine and complementary strategies in combination with conventional therapy. So if you can see this graphic, integrative oncology really is the umbrella around a team of providers for someone who may be on the cancer continuum somewhere. So that would be your naturopathic doctor, me, medical oncologists, surgeons, radiation oncologists, and then there are the patients. And so the patients are really at the center of an integrative oncology approach. This is the bulk of my practice. The bulk of my practice is working with women who have breast cancer. And what I'm trying to do as an integrative oncologist is make recommendations regarding diet and lifestyle, natural compounds that might be helpful, with the goals of reducing the malignant tumor growth, reducing the risk of secondary recurrence, improving overall disease outcomes, reducing side effects of medication or long-term side effects of treatment, enhance quality of life, and also reduce other things that might be a problem, like cardiovascular disease, diabetes, etc. Different clinician partners who would be part of an integrative oncology team would be naturopathic physicians, particularly those who have a naturopathic oncology board certification, like myself, acupuncturists, and there are acupuncturists who are specifically trained in oncology, manual therapists, massage therapists, mind-body practitioners, the palliative care team, and all of the other providers that might be part of a conventional program. There's been a need for specialization in integrative oncology. as a discipline to standardize safe, effective, and evidence-based treatment for cancer. So this is the lens that I see everything through. FABNO means Fellow of the American Board of Naturopathic Oncology. I've been a FABNO since 2009. It was a rigorous training. You can see here on this slide that it required quite a lot of time, patient contacts, examination, and effort. There are 10 to 15 FABNOs in Washington state, but there are only about 117 total in the North American countries, the United States and Canada. That's where we're licensed. So let's talk about breast care, but first I'm gonna check in here and see, are there any questions? No, no questions. Okay, hopefully you're viewing this all right. So let's go back to my slides. So minimally for breast care, you wanna be paying attention to them. Your breasts are a very important part of your body, and sometimes women won't pay any attention to them at all until there's a problem. But at the very least, you want to take care of your breast skin. Make sure that your skin is not overexposed to the sun. Often we get sun damage right here on the chest above the breasts. That can result in a basal cell carcinoma, a squamous cell carcinoma, can cause lots of discoloration. Depending on how low cut of a bathing suit you wear, it might actually affect the breast tissue. So minimizing sun exposure is really important. Wear sunscreen and moisturize your skin. If you treat your face with a good moisturizer, also treat your neck and your chest so that you get as much of that tissue as possible. And after showering, you can moisturize the breasts as well. As we get older and our estrogen levels go down as women, our skin tends to get drier naturally, and we need more moisture. So that moisture comes from within, drinking lots and lots of water, but also can come from without, using different kinds of lotions and creams. I always recommend using products that are natural. You can even use something as simple as coconut oil if you like the smell of that. You can use shea butter. There are lots of great simple products out there. If you have questions about the beauty products that you use, go to EWG.org. That's the Environmental Working Group.org. And they maintain a really good updated list of beauty products and the ingredients in them. And they rate those products based on the ingredients and whether or not the ingredients are things that can be damaging in different ways. So good skincare and sun protection are really important. Just a note about sun protection, hopefully you're using reef safe sunscreen, especially if you're getting into the Pacific Ocean or the Atlantic Ocean, or frankly any ocean, as sunscreens that are not reef safe sunscreens can be damaging to sea life. Pay attention to your breasts. Look at them in the mirror. Note the shape and color of the overlying skin, the areola, which is the circle around the nipple, and the nipple itself. As we age, those parts of the breast can change in color and shape. Certainly the nipple and the areola can darken and thicken and change with breastfeeding. I do have one note here that if you are a newer mom, a woman of childbearing age, and you have the opportunity to breastfeed your children, do so. Women who breastfeed their children have a lower incidence of breast cancer overall. Breastfeeding is breast protective. So, but breast skin does change over time. So pay attention to the skin, the areola, and the nipple. Do self breast exams regularly. And a good self breast exam has your arm up in the air or leaning against the shower, if you do this in the shower or another wall. And when you do a breast exam, you want to examine your armpit, all the way down, and try and do it like almost like pie wedges. You're feeling at different depths all along the breast in sort of a spoke-like pattern. And you definitely want to feel under your armpit as well. Doing an occasional self-breast exam will help you familiarize yourself with your breasts and whether or not anything might be amiss. Sometimes I get the question about whether or not we should be wearing bras at all. I do think in general, bras are, up to your comfort level. And certainly some bras are more comfortable than others. Thank God we're not in the corset age anymore. Underwires, of course, can be very uncomfortable, but it depends on the size of your breast. So what you want is a supportive but not binding bra. And getting a bra that fits appropriately is also really important. It's really hard to buy bras off the rack if you haven't tried them on. And there are different measurements that need to be taken underneath the breasts, over top the breasts at the level of the nipple, and then understanding cup size. And there are professional bra fitters at places like Nordstrom's. They may or may not be doing it right now because of the COVID-19 pandemic, but in general, good department stores should have well-educated people in their lingerie department to help you get fitted for a bra well. Something that Nordstrom's also has done historically is helped women get fitted for post-mastectomy bras that might need to have a prosthetic inserted into it. So Nordstrom's really has the bra department that I would send people to if they're in need of one. So breast density is a big issue when it comes to breast health. 75% of women in their 30s have increased breast density. 25% of women in their 70s have increased breast density. Almost half of women have dense breast tissue. And the reason dense breast tissue is a problem is because mammography becomes less sensitive when a woman has a very dense breast. Women whose breast density does not diminish over time. So you can see with this data that when you're in your 30s, you might very well have dense breasts, but then as you age, that density lessens. For women whose density does not lessen as they age, these women are at higher risk of being diagnosed with breast cancer. So here are a couple of images of breast density, and this is a radiology classification. You can see in this image on the far left an almost entirely fatty breast. It looks pretty almost fluid, net-like kind of. And then as you go towards the images on the right, you can see the density is increasing. There's more almost matting until you get all the way to the right-hand side. And in comparison with the breast on the far left, the fatty breast, the extremely dense tissue on the right-hand side really obscures the ability to see anything else that might be in there. It's almost opaque. If you look at that third image where it says heterogeneously dense, for an untrained eye, you could look at that and say, wow, that looks like maybe a tumor. Obviously, a mammographer is extremely well trained in examining this kind of data, but a very dense breast may obscure even a trained mammographer's ability to identify what's just breast density and what might be a tumor. So fibrocystic breasts are sometimes part of this dense breast phenomenon. And if you have painful, lumpy breasts where you can actually feel the lumps in your breast and they're very tender, particularly cyclically, you may have fibrocystic breasts. You most likely have very dense breasts, and then sometimes there are these little swelling pockets of fluid that go up and down with your menstrual cycle. Fibrocystic breasts can be aggravated by foods that are in the category containing methylxanthines. I know that's a really big biochemical word, but it's an important one because it encompasses chocolate, one of our favorite things, and caffeine-containing beverages, another one of our favorite things. So the methylxanthines, which are found in both of these categories of food, chocolate and caffeine-containing beverages, can aggravate those fibrocysts. So if you tend to have a diet that's very high in chocolate and caffeine-containing beverages, and you have painful breasts, you might be aggravating your breasts with those food choices. So I would recommend trying at least 3 weeks without those things if you can. There absolutely are some good substitutes to help with sweet cravings and waking up in the morning. And see if that makes a change in your breast health. Fibrocystic breasts can also be helped with natural compounds, an overall lower fat diet, increasing fiber in your diet, which often you get from vegetables, but sometimes you need to supplement with a fiber supplement, eating more seafood and seaweed in your diet. That's particularly from iodine. Iodine can be a very helpful compound used with caution, but iodine can be a very helpful compound to alleviate fibrocystic breasts. Vitamin E, vitamin A, and EPO stands for evening primrose oil. Those are all nutrients that can help over time to diminish the severity of the fibrocystic breasts. Diuretics, herbal diuretics, these are plants that cause fluid and waste to leave the body. These can be drunken as teas, can be helpful to flush out some of the inflammatory products of fibrocystic breasts. There are a couple topicals that can be helpful for fibrocystic breasts. Poke root oil. Poke root is also known as phytolacca for those of you who are botanists out there. And progesterone cream, although I would caution progesterone cream needs to be used with caution if you are high risk for breast cancer, or you already have breast cancer, or you have had breast cancer. I would not use progesterone cream in those cases. And liver support is a very important key aspect of naturopathic care. The liver is the seat of detoxification. So everything that comes into your system has to be processed by the liver in some way, shape, or form and metabolized and excreted. And that also includes hormones. So with painful lumpy breasts that fluctuate with your menstrual cycle, there is a hormonal element to that cyclical nature of pain, and your liver has to be in really good shape to help you metabolize the hormones that are circulating at those times. So liver support might also be part of a program to deal with fibrocystic breasts. So dense breast tissue is different from fibrocystic breasts, but they often go together, and the fibrocystic part can be the one that causes pain. So let me just, before I go on to screening guidelines, I just want to see if there are any questions. I don't see any questions, so I'm going to go back here and talk about screening. So mammograms are the primary tool that we have for screening the general population. And there are different organizations that have made various recommendations over the years. There has also been a significant examination of all of the recommendations regarding mammogram. This was done in the early 2000s, I would say, by the U.S. Preventive Task Force. And there's definitely a little bit of controversy about the frequency of mammograms, although in general, The American Cancer Society, the National Comprehensive Cancer Network, and of course, all the radiology organizations say that mammograms should begin at age 40 and continue annually until at least age 70. The US Preventive Task Force examined all the data and found that really mammograms between ages 40 and 50 didn't make that much of a difference in terms of overall mortality, meaning deaths from breast cancer. But people have become leaders regarding their own health care, and more women seek out mammograms starting at age 40 based on their anxiety about anything that might go wrong with their breasts. Now, women who are high risk, meaning women who have a first-degree relative who had breast cancer or a known genetic mutation, these women should be having mammograms starting 10 years before the diagnosis of the first-degree relative. So, for example, if you are a woman, let's say your mother had breast cancer diagnosed at 40, then as a woman who might only be 29, you should start having your mammograms at 8. Well, that wouldn't really work, would it? No, yes, it would. Start having your mammograms at 30. Your mother might be, 60 by that point. At any rate, I recommend annual mammograms. I recommend mammograms that start at 40. My feeling is an ounce of prevention is worth a pound of cure. And mammograms are easily available in most communities, in major metropolitan areas. In rural areas, obviously, it's a little more challenging, but all of these organizations can help find the closest mammography to you. So some benefits of mammography, and this is a lot of data, but I wanted to list it anyway. Overall, what the data say here is that mammography starting at age 40 saves lives. And I think that that is really the message that we need to take home. Young women with breast cancer tend to have more aggressive breast cancers. And if they're caught earlier, then more treatment is available. So yearly screening really has made a difference. Follow-up testing risks of mammography screening, recall is really uncommon. Only about 10% of women are called back. And of that 10%, only 2% actually have to undergo a biopsy. So typically with mammography, women will have their appointment for a mammogram, and then if they have to have further imaging done or an ultrasound done, they'll be called back for that. There are very few organizations that will automatically do an ultrasound immediately following mammogram. It's a procedural issue. I think it's also an insurance issue. So there is that time lag, which can cause anxiety. And that's a big deal for a lot of women. But unfortunately, that's the way our system works in most places. But if you keep in mind that only 2% of women actually have to undergo biopsy, then that's, in general, a pretty small number. Other concerns that women have about mammography is the radiation involved with a mammogram. A lot of women don't want to have a mammogram because of radiation exposure. However, a very large study that was done of 100,000 women undergoing annual mammography from the ages of 40 to 55, and then every other year until 74, showed a 0.086% risk of developing any kind of cancer stemming from that radiation exposure. And the amount of radiation that actually is administered during a mammogram is no more than the amount of radiation that you would experience if you got on an airplane and flew somewhere. So we are exposed to radiation in our daily lives on a regular basis. And A mammogram, if you only have to do it once a year, it's like flying an extra airplane flight. Thermography is something that people would like to be able to hang their hats on. Unfortunately, thermography is not a viable alternative. There is no supportive scientific evidence of thermography. And just the way things work in our healthcare system, biopsy cannot follow a thermogram. Even if the thermogram is abnormal, a mammogram still needs to be done. That's just the way our insurance system works and the way our healthcare system works. So I do not recommend thermography. Digital breast tomosynthesis is a 3D type of mammography. Most breast centers that are in major metropolitan areas these days have digital breast tomosynthesis. It's an even more sensitive form of mammography that reduces false positives. And in women with dense breast tissue, digital breast tomosynthesis actually increases the rate of cancer detection. So that's a good thing. It's pretty significant versus digital mammogram alone. So if you know that you have dense breasts, I would seek out 3D mammography or digital breast tomosynthesis, and definitely ask wherever you have gone to get your mammograms done, whether or not they're using DBT or they're using more old school mammography. That can reduce actually the number of times you would get called back if you get called back. So what if my mammogram shows something? So again, of the 10% of women who get called back after a mammogram, only 2% are going to have to undergo biopsy. Biopsies are in-office procedures, generally 20 minutes or less if done by a skilled radiologist, and they're relatively painless. You get a little bit of local anesthesia and boom, it's done. Pathology generally takes a few days to come back, but we can understand a lot about what's going on from that biopsy. So I believe that it's worth doing. The biopsy can show calcifications. Calcifications can be a precursor to DCIS, which is ductal carcinoma in situ, a very encapsulated early stage breast cancer. Biopsy can also show malignancy. Pathology looks at the cells and the nature of the cells, and you can determine if something is benign, which means it's not cancerous, or malignant, which means it is cancerous. So that's what a biopsy would show. But only 2% of women who get mammograms annually have to do that. Try and remember that. So diagnosis, if that biopsy comes back with some kind of pathology that's concerning, 85% of invasive cancers are found on screening mammography. Only 15% of invasive cancers are found on clinical exam. And that's because even if you're doing a self-breast exam or you go for your annual visit with your primary care physician and he or she feels your breast and tries to find lumps, sometimes if there is a tumor, if there is a lump, it might not be something that can be felt. So that's why mammography is so important, because there's all this tissue of the breast that you really can't feel from the outside and you can't see from the outside. So a lot of tumors are deep inside the breast or up against the chest wall, and only mammography is going to find those. Certainly, there are some risks for being recalled for additional imaging. Needle biopsy, scanxiety is very real, meaning being really afraid of what the imaging is going to tell you, and certainly overdiagnosis. All of these, however, are non-lethal issues and sometimes just need to be gotten through to be able to get the result of, is this cancer or is it not cancer? And again, today's treatment for breast cancer is most effective when breast cancers are caught early. So that's why we want people going for their mammograms. Additional diagnostic measures beyond mammogram, MRI plus mammography combined have a higher sensitivity than ultrasound and mammography combined. The recommendation for MRI and mammography often has ultrasound as a stepping stone because insurance companies don't like to cover MRIs because they're very expensive, but MRIs are for sure the most sensitive diagnostic measure. MRIs are not practical for screening the whole population. That's why we rely on mammograms. Mammograms certainly are not perfect, but they're the best we have to screen all women. MRIs are definitely more sensitive. They can identify cancers way more often than mammography can, but again, it's not practical for large populations. MRIs are generally reserved for high-risk patients, again, women who either have had cancer or have a first-degree relative who've had breast cancer, extremely dense breasts, like I mentioned before, or a positive finding on mammogram. So overdiagnosis really is one of the biggest issues with doing screening mammograms. And, we've come to this place where imaging is very, very sensitive. And sometimes a mammogram will find a very small, very slow growing breast cancer that is more often than not going to be something of great import for a woman. It would be a sort of small, slow growing, smoldering issue if a woman could live with it. And some women do, but some women have a hard time knowing that there is something potentially growing in their breast. So a mammography or a mammogram can find these very small, very slow growing cancers. And then you've got a diagnosis, and then you have to figure out what to do with it. And in today's healthcare environment, what ends up happening is that mammogram trips this whole cascade of the cancer process. And if you have a biopsy that is positive, you will be sent to a surgeon. You will be sent to a medical oncologist. You will have more appointments and more information thrown at you in a very short period of time than you ever imagined. And overnight, your life can become very, very complicated. And depending on the diagnosis, that may be warranted. If it's a very large breast cancer, obviously we want to be expedient with the care for that woman. But in these very small, very slow growing cancers, let's say in a woman who is 70, who has other issues that might be going on with her health, like high blood pressure or congestive heart failure or osteoporosis or other things that she might have more danger resulting from, then she finds herself in this cancer cascade of sort of emergency, which may or may not really be an emergency. So that's the issue with overdiagnosis. Some breast cancers are not going to kill a woman within her lifetime. For example, DCIS. DCIS has the percentage or has the potential to turn into an invasive breast cancer. But a lot of DCIS just kind of stays as DCIS. It's a very small, very slow growing cancer. However, underdiagnosis is not ideal either. We don't want to miss women who have an invasive breast cancer that really needs to be treated. So that's why we're stuck with this imperfect screening tool called the mammogram. So any questions so far? I don't see any questions. So hopefully this is helpful. Let's talk about genetics just a little bit. So I've mentioned a couple of times a first-degree relative with breast cancer really is when you have to start thinking about at what age do you get a mammogram and is genetic testing warranted. BRCA1 and 2 are really the most famous genes that are related to breast cancer. In parentheses there, I have written color. The color test is a very simple test that you can order online, and it gets sent to your house, and you provide a sample and send it back, and they tell you whether or not you have a BRCA1 or BRCA2 gene mutation. Those are the most famous genes regarding breast cancer. There are other genes, and there are other panels that can let you know whether or not you have any of those other genes. If you know you are of Ashkenazi Jewish descent, that population has a much higher incidence of breast cancer. And so those top three things I have there in my list: first degree relative, BRCA1, BRCA2 positivity, or Ashkenazi Jewish descent, those three things automatically make you high risk. And you need to connect with a breast surveillance program and possibly a geneticist. There's different testing that occurs in the evaluation of one's genetics. A genetics panel is typically what you would talk about with a genetic counselor. Most large medical organizations in metropolitan areas have a designated genetics counselor, and these folks are well trained in figuring out your family history, your family health history, and where genes might be a problem. And I've just put down here a couple of examples of genetic panels. Myriad Genetics and Invitae, these determine inherited traits that predispose for cancer, like BRCA1 and BRCA2. Both of those are included in those two panels, but those two panels also have a whole bunch of other genes that they're looking for. Genomics testing is a little bit different, and genomics testing really is only used if you have a cancer diagnosis that is invasive disease. So the FoundationOne genomics test is just one example of this kind of testing. There are lots of other tests and more coming onto the market. This particular test looks at tissue and determines the behavior of the cancer cells themselves and whether or not there are any treatment targets on those cancer cells. So maybe you've heard in the news or you've seen advertisements in magazines for different drugs for cancer. I just saw one the other day. It was about Opdivo. Opdivo is a drug that's used for lung cancer. And it has a very specific treatment target that was identified using genomics science. So there's a difference between genetics testing and genomics testing. Then there is this more sort of popular testing, which is focused on SNPs, SNP, or single nucleotide polymorphisms. So the test 23andMe is one that looks at single nucleotide polymorphisms, and these are very small changes in the genetic code. My feeling is we know a fair amount about particular genes, otherwise known as oncogenes, that cause cancer. BRCA1 and BRCA2 are prime examples of oncogenes, genes that cause cancer if you have them. There are other genes that we're starting to understand that relate to how your liver processes. Remember, I talked about liver support as being important for fibrocystic breasts. And dealing with that issue, but there are genetics related to your liver, to your kidneys. Those are the two places where you detoxify from things that come into your body, whether it's been your exposure to pesticides, herbicides, toxic elements in your workplace, mercury. There are lots of things that we can become exposed to over time, particularly over an adult lifetime. And where you might have grown up, that can create this burden on the body systems and influence how genes behave. And so these single nucleotide polymorphism tests are interesting science, cutting edge science, in some cases, actionable science, but not at the level of genetics panels and genomic testing, which, as we say, those are ready for prime time. Single nucleotide polymorphism testing is not quite ready for prime time, but certainly can be considered in the mix of one's overall care. And then there's this idea of epigenetics. And so the oncogenes, the genes themselves, are on your DNA, which is a double helix. And branching off of your double helix are these little proteins called histones. And the histone proteins act like on and off switches. And because they're on top of that double helix, we call studying those histone proteins and their behavior, we call that epigenetics, on top of the genetic code. And so those histone proteins can be influenced by the environment around the genes themselves. So this is I call it your biochemical terrain, the metabolic milieu around your DNA, around your cells, that influences how your DNA behaves and whether or not genes that might be a problem get turned on or turned off. That's epigenetics. So it's the environment around the genes that influences their expression, and that environment can be influenced by diet, hormones, inflammation, and lots of other biochemicals in that milieu. So correcting your biochemical terrain, if we can actively identify what's going on in your biochemical terrain and influence that, then we can potentially have a positive influence on cancer development and cancer treatment. And this is really where natural medicine shines. This is where we're bringing in the ideas of nutrition, lifestyle, natural compounds, mind-body techniques, bringing that all into the integrative oncology picture. So this is me. I'm Dr. Laura James. I practice in Bellevue, Washington, and I have just opened a practice on Maui in Hawaii. If there are any questions, I will take some questions. Let me get out of screen share if I can. There we go. Don't know if there are any questions, but I thank you for your attention. I hope this was helpful in providing an overview of breast health, breast screening, what happens with a cancer diagnosis, and genetics. If you have any additional questions, you can reach out to my practice at info@laurajamesnd.com. And also, if you have any ideas for things that you'd like to hear me talk about, I'm trying to do one of these Crowdcast events at least once a month, and I'm trying out different topics. So I look forward to hearing from you, and stay well, take care of your breasts, and good night.